are 3 out of the 4 SEOW members are on board though, so we'll go ahead and get started. So I'm going to open the March 7th, 2023 Strategies on Evidence and Outcomes work group. We are meeting remotely, and the agenda is there in front of you. We are getting into the nuts and bolts today of what we're going to be recommending for the new plan year. We'll start with the February meeting synopsis. We then go for an hour around medical, dental, vision benefit design recommendations. We have a break, and then we have another hour where we're going to be looking at PEB and OEB clinical quality performance measures. Today, my guess is that because we're going to be, particularly when we get to the clinical quality performance review and such, we'll be looking at both OEB and PEB. And do we have PEB members joining us today?
Kimberly's here.
Great, thank you. Okay, so with that, as I say, Jeff will join as he is able to. And the February meeting synopsis, the two things that I wanted to highlight before we approve that is, Robert, you had asked how Kaiser medical initiatives factor into their overall rating model, and hopefully we'll be able to hear about that. The plan was just to bring that forward to today's meeting. And same thing, we had asked Mercer to gather more information about the financial implications of some of the design recommendations. So I know that our consultants have that teed up, so we'll be able to look more at that as we go through things. So otherwise, is there a motion to approve the synopsis?
I move to approve.
And I will second.
All in favor?
Aye.
Aye.
Aye. Okay. So we've got that part done. So now we are on to the 2024 medical, dental, vision benefit design recommendations, and this is where we put on our evidence and outcomes hats, and away we go. Who from our consultants is going to lead the conversation? Kirsten, is it you?
Yep. Hi, Tom. I'll kick things off this morning, and then I'm going to pass them off to Dr. Chuang.
Great. Thank you.
Great. And Maggie's running the deck. So Maggie, if we want to go forward, the first part of the deck takes a second look at the initiatives that were introduced last month, and we'll address the financial piece that you mentioned, Tom. And then the second half of the presentation is going to circle back to some of the clinical initiatives that we introduced last month and talk about evidence and next steps. And Dr. Chuang is going to lead that part of the conversation. So let's go ahead and roll forward. Kaiser brought forth a suite of initiatives focused on innovative treatment solutions, specifically digital therapies, at-home therapies. So giving members increased access to treatment through new treatment modalities. We did go back to Kaiser and ask them to provide the individual cost components. And as we talked about last month, it doesn't work. It doesn't work like that for Kaiser, but I will highlight how it works. And this is what Kaiser has provided instead. Kaiser, with their integrated delivery model within their health insurance, I'll call it like a health insurance wrap over their delivery system model. They make decisions at a national corporate level, deciding what we need to do to increase access for our members, what new therapies is our clinical evidence team bringing forward, how do we as a provider group first, insurance companies second, how do we want to change that we provide care? And then they make that change on a national level for their groups. And that is really reflected in it's more of like an investment that they make, right? And is reflected in just their general, I got muted. Maybe I'm unmuted.
Yeah, this is Tom. There's someone who is on who is not muted, and we're hearing occasional call out. So could everybody please check and make sure you are on mute now? Thank you. Go ahead, Kirsten.
Yeah, perfect. So just to wrap it up, the way that these investments were made was a holistic investment by Kaiser to advance. Oh, no problem, Cindy. To advance the way that care is being provided for their membership. And so it's not an incremental menu of cost changes that OEB can opt into or out of. And even then, just for informational purposes only, because of the holistic nature of the investments, we don't have the individual cost. It's rolled into Kaiser's integrated delivery model. But what they did highlight for us is their thinking behind these changes and what they were going after for their members. So for high-tech sepsis treatment, I think I mentioned this last time, there's some really interesting podcasts about how tricky it is to actually treat sepsis and what the digital therapies that monitor real-time bacteria levels in a member, how they're able to advance care. So this is a really cool space just for people who want to geek out a little bit on innovative treatment. Kaiser is saying that this program is going to influence member quality, member experience, and also affordability. Maternity at home, same thing with the addition of increased access. Our thought was, and again, it's not necessarily a choice for OEB to opt out of, but these are good initiatives that will help your members and do what they say they're going to do. So we did think that the recommendation from Mercer's perspective would be to accept the changes. Tom, do we want to go through all of the Kaiser initiatives and then circle back, or just as we go?
I think that we can go through if a SEOW member has, or one of the PEB members have any concerns as we're going through, go ahead and stop. Otherwise, I would like you to go through all of them, and then we'll kind of finalize.
Okay, great. Maggie, next slide. Kaiser also proposed an expansion of their remote patient monitoring system, again, improving quality, member experience, access, affordability, enhanced program to safely transition members from skilled rehabilitation back to their homes, leading to a reduction of hospitalization rates, quality, member experience, access, affordability here as well. Maggie, next slide. In urgent care redesign, reducing the time spent in the urgent care and allowing an additional 17 appointments per day, which obviously increases member experience, access, ultimately affordability if we're seeing people in the urgent care as opposed to the ED. Kaiser Permanente at home, bringing hospital services in home, and then e-visit chat and Get Care Now, increasing access to care. These are lower cost modalities of care as well, addressing member experience, access, and affordability. So that's the suite of Kaiser programs. Again, these are digital therapies that increase access by being performed in alternative settings, specifically in lower cost settings to the alternative. So they fit in with OEB's efficiency goal for sure. And Mercer's recommendation was to accept all of these changes as well, or endorse them as it were.
Any questions or comments from SEOW? Robert, does this answer your question about how the model is, how the initiatives play into it?
It answers the question of whether we have any controller say in it. So yes, it's clear.
It sounds like it's all or none. Meaning this is what they do.
Yeah, it's more like when we partner with Kaiser to provide care, we're putting our vote forward to Kaiser to provide care in the best way that Kaiser knows how to do it. And for the 10/1/23/24 plan year, Kaiser collectively, again, thinking as the physician group, Kaiser's made the decision that this is the way that they can best provide care to OEB members. So it's really an advancement of their overall model.
Got it. Okay. Is there, again, if there's no issue that any of the SEOW members have, I would assume we accept our consultant's recommendation and forward this to the board. Going once, twice, sold. Onward.
Onward, let's look at some MODA medical initiatives. Oh, Kaiser had 3. Thanks, Maggie. Kaiser had 3 benefit changes that align. In the first case, colorectal cancer screening coverage, aligning that with the United States Preventive Service Task Force. None of these had material cost impacts, by the way. Adding a naturopathy benefit for out-of-area dependents, and then lowering insulin cost share from $75 to $35. Our perspective certainly is that keeping pace with the USPSTF is important for preventive care. The out-of-area dependent change is more procedural. Lowering the insulin cost share cap fits in with what Dr. Chuang is going to focus on, which is really the need for this holistic metabolic disorder treatment strategy. So Mercer was supportive of these 3 benefit changes as well.
Sounds great to me.
Great. All right.
Again, any concern from SEOW members or PEB members, please jump in with a raised hand, and we'll go through it. We have obviously a ton of stuff to talk about. So on to MODA.
Great. Let's work from the bottom up, because I think that's going to be the simplest way to do this slide. MODA had proposed some really interesting programs, really targeting needs within the social determinants of health space. Those were meal programs that would bring healthy food to members with certain chronic conditions initially. It's part of a Medicaid pilot. And then flex funds are a pool of funds that a care team can use to help meet social determinants of health needs. So again, really innovative solutions in an area where there is a lot of interest and need. But there are some tax implications to these benefits. Specifically, they would be treated as taxable income to the employee, which has some complex implications for payroll. And due to how payroll is administered and those operational considerations, that's a more complicated discussion for down the road. So we're going to say it's not doable for 10/1/23, just based on the operational considerations for those benefits. Expanded language services. This is an expansion of their interpretation services, both in person and virtual. There's a negligible cost impact to it. We hope members take advantage of it. We don't know exactly how many at this point. Our recommendation meant to update this from TBD to accept. And then the last one, we'll mention it here, but maybe we could hold off. It will come up again, as Dr. Chuang talks about holistic metabolic disorders. MODA is proposing adding a program called VERDA. Providence put VERDA in place for PEB last plan year. And VERDA is a treatment solution for type 2 diabetes that focuses on type 2 diabetes reversal through diet, specifically through the keto diet. And this is part of our discussion we had last month as well, and we're going to have it here again, and we're going to have it in the board as well, which is, when we identify an area where our members are, they need additional support with their chronic conditions. And we identified last month that we have major cohorts of people with diabetes and obesity. We know that a long-term treatment strategy is important. We have to be bringing solutions to these members and getting them engaged and making an impact over time. And we also talked last month about when we bring a new solution to our membership, there's an initial cost to that program. It's a new program, members start to see new providers, get on new treatment regimes. And even though we begin to impact their care immediately, it takes time for the financial benefit of improved care to start flowing through to the claims. As we talked about, maybe in the CL meeting last week, as an example, with obesity, if we begin to reverse obesity as somebody's BMI drops, they may still have some joint issues from when they did have obesity that we would see down the road that we would have to address as well. So the way that Verta is shown here, I really wanted to illustrate there's a cost 1 and a cost 2 impact, and they're different. In year 1, we think of the program as an investment. So the net, so maybe the cost of the program would be $1.23 with some anticipated savings, maybe towards the end of that first plan year. We do start to see some medication deprescription and some savings as a result of that program. But in year 1, it is a net cost. Just to put it in perspective for people, 20 cents PEPM is a little more than 100 grand for OM. And then in year 2 and beyond, now we start to see a net savings. And the net savings for year 2 would be $1.52. And as people continue to, maintain gains that they gained when they were on Virta, they stay deprescribed. We get the benefit of that lower prescription savings for the rest of their membership with OEB, for example. So I don't know if you want to vote on Virta now, or we'll circle back to it again as part of the holistic treatment strategy more when Dr. Chuang is talking. But our recommendation would be to adopt Virta as part of a holistic treatment strategy.
Well, the question for you and Dr. Chuang would be if whether or not you view Virta as a possible standalone recommendation. So let's say I understand it as part of what you're going to be proposing for the larger area of obesity, metabolic syndrome, and diabetes. So I understand that. But as a separate entity, I could imagine we would say, no matter what we do with the rest of that, we'd want to do Virta. So if that's the case, so if your recommendation would be, yes, we would do Virta no matter what, then I think that we should have a specific recommendation for Virta. My personal opinion is that it makes a lot of sense to try. I like the idea of using funds, and this is a larger conversation I know we're going to have this afternoon with the board around the use of the RSR funds, but what a great example of something where one can fund an innovative process and with the idea that you start getting reductions in costs as you improve quality in the future. I mean, that's obviously win-win.
Yeah, I would agree that I think there's merit for Virta to be a standalone because as a broader population of individuals with struggling with weight management, there is a potential benefit and alignment with the Virta approach and their program with certain population.
Super. And Jeff, you had a question.
Well, not a question so much as a statement.
A comment? Yeah.
A comment, yeah.
Great.
So if we need a motion or we need agreement, I would say that we go forward with this pending a discussion on how we finance it this afternoon.
Okay. And the good news is we don't have to do the finance part. From a clinical standpoint, I think we'd say this makes sense. And
Yep.
Obviously it needs to be fit into a budget. We're saying the same thing. I agree with you
Yes.
100%. We're saying
Agreed.
the same thing. Yeah. Okay. Any other comment from SEOW members? Kirsten, I'd love to hear it. Did I hear you say Providence brought it on this current year?
Yes, that's correct.
Okay, so the good news is we have obviously the year is too short to know what's been happening, but but when we have a conversation next November, December, hopefully we will have some information from the Providence experience on Verta.
Yeah, absolutely. That will be really interesting. I'm also, this didn't come up in this conversation, but we had 2 new programs, 10122 as well for OAB around pre-diabetes that we don't have quite enough data on yet to make any sense of, but it seems like there's an opportunity to come back later this fall or midwinter and have a clinical review of evidence around diabetes treatments.
Yeah, with Verta and with the, is it Omada and Livongo?
Livongo, yep, and
Livongo.
MODA's pre-D program, exactly.
Right, and MODA's pre-D program. Great. Okay,
Yeah.
so that's on the books. We'll get the, Glenn, obviously, you need to make sure that gets put into our work plan. Okay, so it sounds like Jeff, I saw a hand go up again. Is that you or is that old?
Got to get the mute button off.
I'm sorry. Go ahead.
After the renewal is complete and all that, could we put on our calendar for next year to look at the prevalence of diabetes? Where I'm trying to go is we've been working on programs for this for over a decade. Are they having any impact? And my suspicion is that it's a stew of communication and programs that are effective and coordination with primary care. But I think we need to have some kind of a benchmark of where we are so we can measure the effectiveness going forward. So just a thought.
Well, and that was my thought as we were, as our second agenda item today is going to be the performance measures, and included in that are some, clinical monitoring of diabetes. The problem is that we just went through the COVID pandemic, which disrupted the members. It disrupted the health delivery system. And so we, unfortunately, we don't have a steady state to be able to look at what the implications of the activities we've done so far. I agree with you. We need to look at that. It's going to be a pretty difficult analysis because of the impact of the pandemic.
It's a good idea, Jeff, for sure. And I won't steal Dr. Chuang's thunder, but part of our approach to a holistic metabolic disorder treatment strategy starts with, hey, what do we have in place? Do we have aligned metrics and targets? Do we have ideas of reporting and studies that we want to be doing ahead of time set up? So we'll definitely address that soon.
So what I'm hearing is there is consensus to be able to recommend Verta. The issue, of course, of how to fund it and whether or not it fits into the 23-24 budgets. That's an issue for the board. But from a medical evidence-based perspective, this is an innovative approach that we're interested in trying. Do we have, obviously this is MODA, do we have anything similar on the KP side of things?
Not around diabetes, no.
Okay, so one of the things that we can ask KP is to see whether or not what their thoughts are with having a similar capacity.
Yeah.
We don't need to, that can be a simple follow-up, and we can talk about that as we do our CL planning stuff.
Yep, sounds great.
I'm not suggesting that they contract with Verta. Again, it's a different model, but if there's certain things that Verta has that we think are very, very appropriate and helpful, we would want to be able to see if that can be brought into the KP system.
Yeah, that'll be a good discussion.
Okay, thank
Yeah.
you.
Maggie, what's next? Okay, so we're going to segue into part 2 of the presentation, and Dr. Chuang is going to lead us there. I did just want to check off a couple boxes here, and then I'm going to save type 2 diabetes, obesity, and doula coverage. And we'll talk about PRP as well. In general, we're really trying to take a multi-year strategy with these initiatives, again, for many reasons, right? We have to be thoughtful about paying for solutions and what's the timing of upfront investment versus long-term return through improved outcomes. We also think about the importance of timing when it comes to implementing these programs, maybe the right way. And by the right way, I mean, we've had time to be thoughtful about what metrics and targets and reporting and performance guarantees and any studies that we want to design ahead of time. All of the infrastructure is in place to be able to allow us to answer questions like Jeff is asking at any given point in time. Are these programs working as expected, and to what degree? And then, also these programs have operational considerations that we'll talk about. Doula coverage is an example. And then as we, look towards innovative treatment, sometimes they're not quite ready for prime time. And PRP coverage is going to be an example of that. And then lastly, Dr. Chuang will talk about type 2 diabetes and obesity and how they together are part of a holistic metabolic treatment disorder. So Maggie, I think that's a good time. Let's segue into the clinical half of this presentation. I'll hand it over to Dr. Chuang.
Thank you, Kirsten. And thank you, everybody, for the privilege of your time and this opportunity for me to chime in and provide some of my clinical perspectives on some of these initiatives. Shall we dive into this section here? And we'll just kind of go more in depth into each of those topic areas. We'll start with the idea and the topic around regenerative medicine, specifically platelet-rich plasma. So just a quick reminder, this is where we take the patient's own blood and spin it down to just get their platelet-rich portion of their blood and use it back in areas where some early evidence suggests that that enhances the inflammatory recovery and response. So not surprisingly, the areas where we're seeing this is in musculoskeletal injuries, in joints, healing. And then more broadly, people are starting to look at it in context of a dermatological and broader tissue and wound healing. So what we do know from research is there is sort of pockets of positive results and outcomes, positive anecdotes. And but what we don't have yet is more of a systematized approach to analyzing this and really understanding what are the clear clinical indications for it, how to use it, how long to use it, and what to expect out of it. So it's that evolution of clinical research from discovery, okay, this could work, this does work, to this is how it can and should work. So we're not there yet. So within your provider community, you'll probably see that certain physicians are providing this, but they're not going to be covered within the OAB health plan. The best and safest sort of clinical context for this would be using it within the academic centers and or part of clinical studies, because that's where those questions will get figured out. That being said, there are providers that are promoting this heavily, because with any fancy new medical technology, there's those that promote it just to make it available. So I cautionally advise members to weigh those versus the more academic-oriented providers who provide this care, often in context of clinical studies. So the recommendation for this, next slide, kind of is to keep a watch on this. Like I said, it's going through that medical evolutionary phase of going from discovery through to getting to a concrete clinical guideline. And but we're not there yet. So from that perspective, it would not be considered standard of care. But like I said, those who seek it have the option to receive this care, obviously through non-covered benefits option currently. Questions about this before we move on?
And this was obviously Mercer's recommendation, and that was within the context of also what our medical carriers, they agree with that, I'm pretty sure.
Yes, they do. And there's process in place, and we're mutually keeping a watch on this because it is
Perfect.
evolving treatment technology or approach.
Great. All right. And if no questions, let's march on.
Okay. The next one is around the doula coverage. Again, quick synopsis. So this is another model, more sort of holistic whole person approach surrounding the maternity care with more personalization, more supportive care model that has shown to be helpful, especially with certain populations, some disparate groups that fall through the crack, or just the medical model isn't aligned to their needs and their challenges with maternity care. And some of the positive outcomes and benefits that were shown is around improvement in less invasive, less procedure being provided as a byproduct of labor and delivery. And some of this is just being there, educating, guiding, supporting that mother with their decision and choices through the labor and delivery process. And it does have support from the American College of OBGYNs in that it can be an effective tool. It doesn't replace the OBGYNs or midwife. It ends up being a complementary stakeholder, subject matter expert there, aligned to the mother and the process of labor and delivery to be a supportive and engaging process. Next slide. So with that said, it is sort of a new and emerging model of care, and hence, the network of qualified and credentialed doulas is still evolving. It can be inconsistent or incomplete in terms of availability and access in any geographical area. So that's something that is in process. But the outcomes are promising, and I believe the need and the opportunity to bring value to certain individuals, expected mothers, is high. And as a point of reference, coverage is being piloted through the Medicaid, including 6 states, of which Oregon is one of them. So it is sort of starting to go out, and through those processes, the network and the availability of qualified providers will continue to evolve as well. So from a care perspective, the feedback was, it's definitely something that is worth considering, worth working towards. It definitely has a value and importance to equitable care across the membership. Kaiser and Moda did communicate back that they are both proceeding with the coverage in the Medicaid side, and that will start to roll, back into the commercial side of things as those operational things get figured out and built out. So the goal is, and the plan is to leverage that because those networks will be built out and they'll be hopefully rolled over into the commercial side. So the recommendation is that definitely doula model of supporting for maternity care is of importance, worth keeping a track on. And there's multiple reasons for that. The social determinants, it can help eliminate some of the disparities in care, help address some of the unique needs of certain subgroups, and lead to clinical outcomes that are more positive than just a pure medical model approach. So the due to the current status, the recommendation would be to sort of keep it on the radar and work towards a later 2024 subsequent year launch for consideration.
Do we know whether or not how in regards to the Medicaid piloting, what's looking at, obviously there's a cost associated with adding people into the care process. And as you noted, there are changes in clinical outcomes that, if you have fewer cesarean sections, you've decreased costs in that way. Do you know whether or not there's much financial modeling built into the Medicaid process? And again, it would be another question for our medical carriers of what type of, as they're looking at doing this with their Medicaid populations, are they paying attention to, the costs, the elements of increased cost and the elements of decreased cost?
Kristen, do you know? I've not seen any from the current pilots going on. My insights are from the research side publications.
Yeah, right.
I can jump in here. I was looking at some research on this, and they did talk about the trade-off of, giving X amount towards a doula, but ending up with a lower cost birth. And so we can dig up some more research on that and provide that, Tom.
Yeah, as much as anything, I'm interested in we have our own research going on now, and it's in our communities with the Oregon Health Plan and the Medicaid. So having general having research that's being done elsewhere, I think is also very meaningful. But I would love to make sure that we're asking MODA and KP to be looking at the cost implications. Obviously, again, it's adding a service, and yet with the hope that that decreases a much higher expense on the medical side and improves the clinical outcomes and improves the member experience. And as Dr. Chuang, as you had talked about, the idea of it really helping some of our at-risk populations that we aren't very good at supporting. So again, I'm very supportive of how we're moving forward. I just want to be able to do as much as we can to line up the stars and the planets so that, come 10/1/2024, we're ready to launch.
Yeah, and I think, Tom, one thing I glossed over it a little bit, but I was on an earlier slide, which is with all of these initiatives, getting in the habit of knowing if we're driving to outcomes on these initiatives, let's plan at the beginning. Let's look for carrier alignment, right? So when we build programs for OEP, carrier alignment between Kaiser and MODA as much as possible. Do we have aligned metrics and goals? What are our target outcomes? How are we going to measure those outcomes? So as part of the operational work that we go through over the next year, that would be one important conversation. So we're able to a year from effective date of the program, look back and have everything in place to be able to measure, okay, how much should we spend on the program and what were our outcomes, clinical or financial?
Perfect. Any other questions or comments on the doula coverage? Again, from SEOW members or from our PEB compatriots. Okay, onward.
Great. So in the summary, we had these listed separately, but I think I'll make the case that it's clinically appropriate and it just makes logical sense that we tackle the two, both type 2 diabetes mellitus, my abbreviation T2DM, and obesity together, because clinically they're part of a continuum, and the two are so intricately related. We know from epidemiological studies that obesity. Half of type 2 diabetes are caused by obesity. Those with type 2 diabetes with obesity have their own complexity in terms of how to treat and optimize their glucose control. So that's a basis for this. And as well, because of the intersect, as illustrated by this Venn diagram, for a good subgroup of the members, we have to think about our strategies as well as the programs, point solutions that we make available so that it makes sense to serve the broader need of this cohort. So I just explained sort of why we aligned, obesity and type 2 diabetes mellitus. Similarly, as we talk about a strategy going forward, not all diabetes are the same and not all individuals with obesity are the same. So we have to think about also the concept of high risk and low risk. And this aligns with the evidence-based treatment guidelines that have recently come out, both for adults and pediatric obesity, as well as for type 2 diabetes. So it just makes sense that we talk through this next section, and I'm going to sort of align to these axes for practical reasons, but also from a programming over time. I think there's an opportunity to be purposeful, to put our efforts where the highest risk and hence the biggest bang for the dollars, both financially, economically, as well as clinically. And to Kristen's point, build that infrastructure so we can drive towards outcomes, measure in a way that leads to a confidence directionally that we're going the right way, and then expand that funnel to start to tackle some of the moderate and lower risks as part of the continuum. So it's with that backdrop that we can go ahead and proceed this discussion. So I think, Jeff, you alluded to the importance of quantifying and getting to that, what's the cost benefit, or more ideally an ROI for all this work. The challenging aspect is this is a continuum, as I try to illustrate here. So for something that we call cardiometabolic syndrome, it really starts from the far left, where there's just certain risk factors. Some of them are genetic, some of them are environmental, and some of them are just the choices we've made in terms of lifestyle and behavior. They can lead to this cluster that we call cardiometabolic syndrome. And a subgroup of these become higher risk of developing first pre-diabetes. So their glucose is starting to go above normal, but you're not quite at that diabetic level. And then becoming diabetic. And in this scenario, it's specifically the type 2, previously called adult onset, but now we know that it also occurs in the adolescent and pediatric population. So it's really type 2 variant of diabetes mellitus. And then further, a subgroup of these, if unmanaged, uncontrolled, will develop the complications. So that is the clinical progression, left to right, if left to its own course. Simultaneously, the financial economic impact is, as we move to the right, the complexity of clinical needs, the cost of care, especially with the complications, grow exponentially. So when we're trying to look for ROI, or the ROI from avoiding high cost care, it really comes down to a couple of options. It is first driving right to left, right? Trying to prevent or delay. Given that you've got diabetes mellitus type 2, we want to prevent and delay the onset of those complications. It's not a done deal. That's the focus on that one phase of it. The other opportunity is when you're in the cardiometabolic or pre-diabetic phase, there's an opportunity to keep you from progressing to full-blown diabetes mellitus. Right? So that's a prevention sort of focus. And we lined up the current sort of point solutions to those dimensions that are in place now, as you can see here. Virta is in place with PEB. I had a look at their initial sort of 90-day experience report, and they're showing for a subset of that group, progression down from being truly diabetic to sort of low risk, well-controlled diabetic, and in some cases they're falling into the pre-diabetic and being able to get off the medications that was one of the goals and objectives. Obviously, for the pre-diabetics, it is about just keeping them there and slowing the natural trajectory of moving left to right. So because of this dynamic, it also has an element of time, right? So none of these are sort of something we tackle in 1 year and we kind of say, we're done. Done clinically nor economically. And it's something that we have to build in as a mechanism to track and evaluate and optimize over time. So that should be the expectation of tackling this population. Next slide. Okay, so this one I wanted to put in context, sort of a near-term versus a long-term consideration. So right now, let's focus on the diabetes type 2, because currently the medications that are showing up as being very expensive and being prescribed is aligned with clinical guidelines. They are the best medications for those type 2 diabetes meeting certain high-risk criteria. So now we have the opportunity to treat these individuals well. They are in place. However, we want to consider how to optimize the value and benefit of those medications from the time that they get prescribed. There are side effects and adverse reactions that can be managed through. And then the third part is, are they getting the outcomes that we expect from them? And if so, do they need to continue on them? Are the intensive lifestyle interventions stepping up and helping to reduce the need of those medications? So that's the outcome that we want to drive towards. To do that, we need to align the prescription of these medications with those point solutions that are trying to address the lifestyle and behavioral mental health contributors to this simultaneously, so we can both get the speed to improvement, but also that durability of that improvement. So one thing we can do, and that's in the near term, is just to start aligning the coverage of these medications, what we call the GLPs and the SGLTs. So those are just the groups of medications that are available that really do a good job at reducing, that improve hemoglobin A1C, which is a marker for diabetes. But for GLPs, they also do a really good job at reducing one of the other risk factors, which is weight. So we want to table for consideration how we can align with our carrier partners to set that utilization and usage of these medications more aligned and consistent. Consider sort of a tracking of the utilization through sort of a prescription recertification to have that evaluation. Are these working for the individual? Are they worth continuing? And then the expectation is when we improve weight, when we improve hemoglobin A1C, we have to let time quantify the clinical benefit because you don't get to sort of diabetes with complications overnight. The risk of it is over time. So when we do improve those biometrics, tracking those individuals and ensuring that they stay in the ideal target range over a period of time gets us that return on investment quantification that we seek. So I think that's what we want to table in the near term for consideration. Next slide. Yes, questions on that? Let me pause there.
Yeah, this is kind of personal curiosity, but is there BMI at which type 2 diabetes is minimal? I guess I can't ask the question where it's done away with, but is there kind of a passage where it's tends to go away, or your reliance on medication subsides?
Yes, so there can be. So for diabetes type 2, not everybody has coexisting obesity. There are other contributing factors, genetics, social determinants, things like that. But the higher risk group, there's a subset, a significant one, which is type 2 diabetes being partially, if not completely, caused by the presence of significant obesity as reflected by BMI. Now, I will state up front, the goal is not to, we're not trying to make everyone skinny. It all comes down to, if this is your current baseline health risk, your metabolism at a certain weight and type 2 diabetes, any meaningful improvement defined by certain percentage drop is a huge lift on that metabolism from an improvement. So it is all about where you are now and getting it to a better level, and then optimizing things as much as we can through those things that are modifiable. Our nutrition choices, the level of physical activity, mental health, sleep, etc.
I've heard that BMI is based on a white male. And so there's some criticism of it. I think it doesn't mean we throw the baby out with the bathwater, but what modifications are there to that?
So BMI was a metric of convenience because it was based on a couple of generally available height and weight values. There can be more specific clinical ways to better assess. So those, for a physician, we have those access to those, and it's waist circumference. There's a subgroup of obesity that carries different risk factors depending on where that weight sits, skin fold analysis and other things like that. So typically that's why getting these medications appropriately evaluated so that they're consistent with the latest treatment guidelines, evidence-based treatment guidelines, is in the purview of the physician, how they want to define it. But from the context, it's broadly, it's this sort of severe obesity is the highest risk. But there are exceptions because of gender and other racial disparities.
Yeah, thank you.
Jeff, the only additional thing is that from a populational standpoint, to be able to track the process over time, BMI is tremendously useful. So, you look at BMI percentage of adult population moving from quote normal to overweight to obese, meaning greater than 30, being able to watch that over time is hugely important. And then when you look at it from a standpoint of different populations, average BMI in Colorado is, 15 to 20% lower than it is in Mississippi. And you correlate it with hypertension, cardiovascular disease, diabetes, on and on, it all tracks with it. So it's a hugely powerful tool, but it's, as Dr. Chuang is saying, is that it really is one that is not something that's the most important thing from an individual, from populational standpoint, hugely powerful. And we've watched it in OAB population over time.
Yeah. Well, there's some other social aspects that we don't need to go further into this rabbit hole, but the stigma of being a diabetic and how you're judged by your peers.
Yeah.
Yes.
It's your fault. You did something bad.
I've been accused of that.
Yeah. No, I've never seen you do anything bad in my multiple years of association with you. So.
Yeah.
Yeah, and we know now better that there's a genetic factor to it. There's environmental impact, and that's also why things don't help when we say we can sort of exercise the way out of this, and that's why when we're talking about these GLP medications, nowhere are we trying to say everybody that fits this criteria should be on it. It's just these are good treatment options that need to be available, discussed with your provider, and then a mechanism to have it covered in a consistent, aligned way across our carriers, with a goal and a drive towards outcomes as in a purposeful way. So when we're looking at the current GLP-1, again, this is the category of the medication. There's just subtle nuance difference between Kaiser's sort of provider-centric protocols-based prescribing versus what MODA has in place right when within any guideline, treatment guideline, it's a clinical interpretation and how you implement it. So that's kind of where we are. And within those parameters, there's just some variance currently in terms of who and how medications can be utilized for the high-risk population. Questions on that? Kirsten, would you add anything to this topic or?
No, I think that's a great way to put it. And we are, again, just like getting a full, robust portfolio of treatment options takes time. Reversing chronic conditions takes time. Also, carrier alignment over, carrier alignment will take time as well. And we're working with our carrier partners on this one.
So one of the goals would be to get more alignment across both for consistency for the populations within each carrier health plan. Next slide. So if we sort of lay this out visually, the opportunity in the near term is, again, we're tackling type 2 diabetes as the target individuals to optimize their outcomes, recognizing that there's an overlay of obesity that makes them higher risk. And part of the risk factors includes the cardiovascular diseases that develop from type 2. So with that, there's an opportunity to get a better consistent alignment of our diabetic prior authorization for some of the more aggressive interventions. Specifically, you already have coverage for bariatric surgery. Right now, the medications for type 2 are also being covered, but to just optimize that so we have ensure that those with high risk, where the treatment guidelines recommend has the best value, biggest impact, because it gets them speed to that improvement, to give them a jump start to be able to sustain that improvement over time. Because all the other programs addressing the mental health, physical health, as well as nutrition, diet, as listed on the right side here, they're tackling this part of it, which is still necessary, right? So even with or without medication or bariatric surgery, these are the general necessary steps to optimize our what we can do from a modifiable perspective. So that's the near term, how we could tackle this and get and seek better alignment across our plans. The next slide, I took the luxury of sort of projecting out and saying, well, over time, how can we further align across not just those type 2 diabetes with obesity as a risk factor, but within the group of obesity individuals, because those extra weight, that cohort over time, there's a higher likelihood of development of type 2 diabetes resulting from that. So that's, from the last meeting, we did some estimation based on what we see within the claims and projected out what that population could look like over time. It's unfortunately a pool of the type 2 diabetes mellitus going forward. So as we stabilize and align around targeting and optimizing the diabetes, we can similarly approach the obesity in a thoughtful way, in a hierarchical approach, to ensure that we are targeting in alignment with the latest evidence-based treatment guidelines, and we're getting that sense of outcomes. And again, it's the same two things. There's the bariatric surgery option, which is already in place, but there's a subset of GLP medications that are sort of FDA approved specifically for just the weight, not so much the hemoglobin A1C and diabetes, but just the weight. And then, like I said, these other components are still important and essential, which is the physical activity, addressing that, the nutrition and diet, as well as mental health. But in both cases, any utilization of aggressive treatment, especially the medications, is with the expectation that we will evaluate and seek ways to sort of reduce the dependency on that for a subset of individuals that it's working out for them. It's not going to be for everybody, but a subset will demonstrate that. And again, the early data from Virta, from the PEP side, is starting to be positive in that regards as well. So this will be the longer term a vision of how we would integrate this more cohesively, provide the necessary coverage to cover the different risk groups within both these population. The one comment I will raise is the risk right now, because of social media and everything else, is the medications for obesity that are not covered right now, the Wegovy and the Saxenda. There are ways to get the weight reduction capability through the medication down here, right? So unfortunately, there are providers and channels to sort of trick the system to get the weight reducing impact of these medications without going through the obesity medication coverage. So that's a potential risk. So just keep that in mind. If we don't address obesity, there's little loopholes that people end up finding to get the medications.
I have a question, Dr. Trang.
Yes.
Do we have are there populational studies that are looking at what you're outlining here, that are long, you were talking about, there's no 1 year, done and, do it and then it's over. It's obviously something that goes on. Do we have populational studies that have looked at both of these tracks and, over the 3 to 5 year period of time, or is this just evolving just recently enough that we don't have that data yet?
We have better longitudinal, longer term studies around the diabetes and the use of GLPs and the SGLTs. And what we've seen in that context is when we get that improvement of both hemoglobin A1C, so the primary focus was hemoglobin A1C as a indicator of diabetes control.
Okay. Yeah.
But the weight came along with it.
Right.
The speed to improvement lended itself to persistent durability of control and stabilization. And when you track those individuals over a 6 to 7 year time frame, it did validate that you are delaying, if not mitigating, the development of those cardiovascular complications.
Yeah.
So
And
basically, it takes about 5 to 7 years to see enough of the avoidance of those cardiovascular diseases.
And is that in are those populational studies in is it 2-track with, let's say, more conventional treatment being the second track, the use of various forms of insulin and metformin and things like that?
There's different permutations and combinations of the setup for those studies.
Yeah.
Some of them were just from a start point of control with and without.
Yeah.
And then some were with compared to the alternatives. So like metformin only, metformin with insulin, which also is impactful and can be effective. What I took away from it was for the right patients, each of these can be successful, right? There's patients doing very well with just metformin, but you kind of have to figure out who are those. And if they're not able to achieve a significant improvement in their hemoglobin A1C, then what do we need to do? Do we have another option? And this may be that option. And like I said, there's risk of side effects that have to be managed through. So it's not for everybody, but for a subset that are high risk. And if we can bring them down quickly and then help them with the modifiable things that they need to do, they're on a better path to benefit.
Yeah, I mean, and the importance of making sure that that we understand who benefits and gains is that obviously there's a huge difference in cost between metformin and the GLP-1s. And
absolutely.
And insulin, the good news looks like with insulin is that the price of it is going to be also lowering, but that cost of insulin had been going through the roof over the last 20 years. So
yes,
very complex, but very thoughtful presentation. I'm sorry for interrupting.
No, appreciate the clarifying question.
In terms of time, we are really at the end of what was set. Now, when I went through the whole pack and looked at the time, I thought I was pretty sure we're going to go beyond 10:05. So I'm not concerned that we've gone beyond it or we've gone up to our time limit, and I'm more than happy to continue things for another 10-15 minutes as we I assume, if I remember, that we're pretty close to the conclusions. Is that correct?
Yeah, I think I can sort of summarize up. If Kirsten, if you're okay with that, I can quickly go through this. So I think, yes, so let's go to the next slide. Some of this is just informational, right? How we're sort of what we're calling high risk. So with the BMI, it is really these categorizations is how we're referencing when we speak to it, overweight, and then the 3 subgroups of obesity based on BMI value. The next slide kind of puts the BMI in context with the complications as one parameter of making those utilization decisions, for example, around GLPs. So it's a combination of BMI plus or minus the presence, whether it's mild or moderate versus severe complications already in place. So those are your cardiovascular complications. Next slide. And this one, I think, is the one that I'll spend a little time just to anchor because, like I said, and these were from very well set up review studies that really quantify when we're saying meaningful weight loss. It depends on the coexisting comorbidity that we're trying to impact. Because if you remember, this is a continuum. The cardiometabolic syndrome is sort of an ongoing physiological process. So it's all about where you are now and just improving it to a meaningful level. I'd be much happier with somebody with still a little bit of overweight, but they're doing everything well, than somebody who seems to be skinny or within target weight range, but they're living an unhealthy lifestyle. So that's the balance. And you can see that's with as little as 5 to 10% for most of these common condition maladies, it's a meaningful impact. Obviously, the harder one that we need to tackle is the diabetes from a remission, and that's why we always talk about that 10 to 15, which is a lot. If you're just relying on nutrition management and physical activity, it will take time. And the GLP medications and or bariatric surgery gives you that jump start for the right individuals with significant risk factors when it makes sense. So that's the context of thinking about what is a meaningful weight loss. It depends on the individual and the risk that they're bearing. Okay, next slide. Just some reference material. As a clinician, in anything we say, we always have to have a comfort level that we're basing it on, science and research. So just some information here, but like I said, most interestingly enough, a lot of activities on the guideline side of the world around diabetes, but I think the obesity is a little behind, but there've been some recent update to a past treatment guideline that starts to suggest that we need to start considering this. And equally important, pediatrics, American Academy of Pediatrics also came out with one that says for a subset of children and adolescents with obesity, this may make sense just because of the severity and the risk that they have. Okay, so let me skip down real quick. Next, can you skip to another one? Yes, this one. So with the medication management, again, when we get to the point of considering GLPs for obesity, it would be similar to how we're thinking and approaching the diabetes. There's options in terms of how we think about managing prescribing. If it's just about optimizing appropriate use, then that's sort of the first couple bars. And PBMs can do it, the carriers can do it. But if we're trying to be more holistic, whole person and driving towards outcomes, then it is about thinking how the prescription coverage ties together with other point solutions that are surrounding that individual with the resources and tools necessary to help them achieve that outcome that we're helping them to achieve. So any of these is a step towards the right, and it all comes down to sort of how we think about a timing and a prioritization of this. And we tried to lay that out in the next, skip this next slide to the following one. So being thoughtful about capacity, speed of change, and alignment, we've kind of laid out a possible scenario to consider and discuss further in terms of how we continue to support our members with nutrition management dieting options, which are already in flight. Look at the pre-diabetes treatment options, because again, if you notice that continuum of around cardiometabolic, all of these are interrelatable. We've got VERDA in place on PEB, but consider the VERDA as the nutrition-centric point solution for those with type 2 diabetes. And we couldn't fit it all in one slide, so the next slide goes to the other two dimensions, which is, and then thinking about how we roll on obesity, initially targeting the highest risk group, because those are the ones that are sort of most urgently in need of that coverage, and then simultaneously seek the carrier alignment around coverage of medications, as well as the point solutions being offered over time, as we kind of laid out here.
Dr. Chuang, I might add one thing too for the group's benefit, because I'm seeing I probably should have put a note here as well, which is Dr. Chuang mentioned, rolling out weight loss drugs in a multi-year approach, and there's a lot different ways to think about which cohort might be appropriate to target first, looking at BMI or comorbidity in BMI or pre-bariatric surgery, and we are proposing that we would work with the carriers on that one. Maybe set up a work group, or at least through conversations, and they would help guide that tiering conversation. So here it's just vague. It says tier 1, tier 2, tier 3. The idea is this wave approach where we target the highest risk members first, as part of a balanced outcomes versus financials approach. And then as we get that first tier up and running and start seeing positive outcomes, savings from that group could help fund an expansion of the program to the next group. Sorry. And so forth. So it's that, but again, that would be done with the carrier partners and in, deference to their clinical input, of course. Jeff.
I would suggest that we keep these 2 pages and make notes below of which we have adopted and which, if any, that we've decided not to do for whatever reason, but that we revisit this each of the next 3 years. So we're not reinventing a framework every year, and it's like keeping track of our progress.
Absolutely.
I think that's an excellent idea. The other thing that Robert, go ahead.
I just want to say I really appreciate the short-term and long-term planning on this. It gives a really good framework of how to approach this emerging issue. Well, the present issue and the emerging issue with the new drug types. I really appreciate it.
What I was going to add was this is a very complex interplay between SEOW, which in this situation is representing OEB, and our consultants, and then our carriers. So I could imagine us trying to find some time during the summer where we could get the clinical staffs from our carriers, some representatives from OEB and PEB and Mercer together, and actually start hashing through this and actually if there's debates around efficacy, we'll have the debate. If we're going to come to we've never been in a situation before that I know of where we have told our carriers what specific treatment elements we want you to cover and how. We've said, yes, bariatrics is surgery is going to be covered, and it's going to be within a center of excellence approach. That's one of the things that we decided. But we haven't said you're going to do, gastroplasty versus, intestinal bypass versus, all the balloons or whatever, all the things that people are doing now. So there's specificity that is suggested here that we need to talk through, and then versus, okay, are we working with our carriers to make sure that we have a thoughtful, long-term approach that deals with what we think is our most serious issue. I mean, I think that if you look at the combination of obesity and diabetes and how it interplays with renal disease, cardiovascular disease, musculoskeletal disease, cancer, all of those, it is probably our most important, impactful issue. So thank you for, you're really getting the ball rolling. Where it goes, it may be a pinball machine a little bit, but we'll work through it. When we have when we have our follow-up discussion of SEOW, let's start brainstorming around how to take this as a framework that you've outlined, but then start at one, as Jeff is talking about, making sure that that we're documenting every step of the way, but coming up with plans that are actually actionable and implementable.
And I would just add, that we also start identifying and setting expectation. Maggie, can you go up to the previous line? Because there are some programs take flight. We can start discussing what we would like to see and track over time. Because we need the data in place starting
right
now before waiting for a report and then saying we would like to see this or that. So
right.
Yeah, thanks, Dr. Chuang. I was going to highlight that as well, that really there's two paths, two immediate action items. One immediate action item is to take inventory of what's available and go through this process of asking, do we have carrier alignment? Do we know what outcomes we're driving to? Are they documented? Do we have the process in place to gather the data and measure it? When is the right time to do that? What happens if the outcomes aren't as expected? So it's bringing current solutions that are already available within this framework. And then the second part of it is continuing conversations with Kaiser and Moda, and Dr. Chuang and I and Sarah Drake had several conversations with Kaiser and Dr. Bachman and the clinical team, and Moda and Dr. Popovich, and we're actually all three coming together again to get a meeting of the minds all in one room. The second part is kicking off this process, which is, as you said, a really complicated interplay between clinicals and outcomes and finances and how many years we're looking at and what's the right order of things and what's the right time frame. But just knowing, the size of the opportunity and the fact that it does take 5 to 7 years, we can kind of go back and visualize that table. Some conditions maybe 3 or 5 years to start reversing, others more 10 to 15. So there is a balance too between this long-term implementation in a really thoughtful way, because it's complicated, and also a little sense of urgency around the sooner we get things rolling, the sooner we can start to bring forward some of those outcomes.
I agree. Any other comments from SEOW members and PEB members? Okay, so in terms of steps, though, that was clear was for our recommendation for Verda. That was, we already did that, and we'll discuss our need to, this is going to be, this is a large amount of work that we're calling out, and yet it has the potential of being um, significantly impactful if we do it right. Okay, if not, and is that the end of your presentation for this first section, Kirsten?
Yes, that's right.
Okay, great. If there aren't any other questions or comments, I'm going to have us be on break for about 10 minutes. And we will come back and actually start talking about performance measures. And included in that conversation around performance measures will be some of the diabetes and cardiovascular ones that, and we'll be able to look at and follow, see what's happened with those over time. So with that, I have it at 10:21. We'll regather at 10:31.
Tom, are you back with a cup of coffee? Hey, Tom, have you come back to your laptop yet?
Bill, I think he must have stepped away.
Yeah, I'm just checking. That's what I'm asking. That's clear.
Let me mute myself because I'm getting lots of emails right now.
Is there a bill that's being and testifying right now?
I'm sorry, what did you say?
Is there a bill in testimony right now? Is that why you're getting lots of email?
Well, it relates to legislature, like they're sending we get emails when one of the bills that we're following is up for committee or has an
Yep.
amendment,
I know.
or yeah, or questions, and
I get them. I get them too.
oh, so you must be signed up with OLS. So
I've got too many bills tracking on OLS. I need to cut it down. Of
oh,
course, I can just
yeah.
wait to the 17th, and the process will cut it down for me.
Yeah, the first week of April, it's if they don't make it through the committee, then
Well, they have to be scheduled. They have to be scheduled by the 17th of this month. So you can
yeah,
get a good feel. You can get a good feel for what's going to happen in the first week of April.
yeah, unless they do, well, they will do some gut and stuffing. So
Sure.
gutting and stuffing, I guess, would be the best, more tense wise, better way to say it. So
But you get a good feel for how many people are paying attention to the particular bill you're following. So
absolutely, yeah, you do. If it does, yeah, they're running out of time to schedule it.
let me try one more time. Tom, are you back yet? Nope, he's not. All right.
Yeah, there's been a lot of this year, a lot of placeholder bills that
Yeah.
anytime you see a bill that says this agency needs to study healthcare, and then
Yeah. Yeah. Well, I like the one that they put in, like, make a committee to study single payer system by 2027. That's a good one.
that's not a placeholder. We'll see.
No, I know that's put that committee together. It's kind of a warning shot across the bow.
Yeah, it keeps getting rescheduled.
Yeah, I know. I'm paying attention to that one. One last hope to see if Tom's back before we go back into session.
Let's see, Tom.
Nah, he's not there. That's all right.
Yeah.
It's already 30 seconds to go, so I was going to ask him for a quick 1-minute lesson, but
Lesson in what?
I'm a victim of watching too much public broadcasting, and Nova did a show on adipose tissue as a body organ, and I was going to ask Tom for a quick lesson on his thoughts. Oh, now he's back.
Yeah,
that's okay. We're time to go, right?
Yeah, it's time to go. I'm sorry. We have construction happening in our house, and I'm having to see how things are going.
Hey, Tom.
Yes.
Can we, at the end of the meeting, go back over the decisions on the plan design changes, so we just have those, just we're all in agreement?
Well, let me tell you what I have written down. First, all the Kaiser medical initiatives, we said okay. We said flex funds and meal programs for MODA decline, accept expanded language services, and yes to VERDA, acknowledging that there's a first year cost and that needs to be figured out. And the regenerative medicine was, that's a process that will be done over time. The doula was so the recommendation was for the regenerative medicine for musculoskeletal and potentially other is watch and acknowledge that it's not currently standard of care. Doula coverage was see what's happening with the Oregon Health Plan KP and mode of participation, and look at launch for October 2024. There was no, other than the Verta, there was no coverage recommendation for October for 10/1/2023 in regards to the obesity and type 2 diabetes treatment changes, in terms of in that there's work to be done there, but that there's that this is very important and meaningful work. That was my take.
Okay.
Does anybody have a different take? I'm just reading my notes.
That sounds right to me.
Okay.
Okay.
All right. So let's go ahead and reconvene. We are now going to be talking about the PEB and OEB clinical quality performance measures. Our goal was to look at our recommendations for the 23-24 plan year, and obviously for PEB it's the year 2024. And attached was some showed what had happened over time, and we'll have conversation. So Kirsten, I once again, you are our main person leading us through this, so you're on.
Hi, Tom. I'm actually going to pass it off to Dr.
Okay.
Twine to walk through the clinical
Wonderful.
guarantees this month. Yeah,
Great.
thank you.
Thank you. Dr. Twang, you're on.
Okay, let's dive in. So we'll start with the medical clinical performance metrics. I think this one, next slide, Maggie. The timeline, we can just get everybody reoriented to the timeline of various metrics that in the measurement period. Kirsten, anything more to add about this other than what we're talking about right now for the 23-24 is the...
No, I more just wanted to have a visual in case any sort of questions come up, because with OEB and PEB, and OEB's 10-1 plan year, with PEB's 1-1 plan year, and the measurement year being a calendar year, and the time delay between setting things in advance for when they go into effect in the measurement, I just wanted to have it all written down in case we had questions about it later so we could see it out.
Okay, thank you. So where we are today is the next slide. Kind of, we, as Tom alluded to, we had COVID, and that sort of kept the metrics going, but we did not tie together the fees at risk during the 2021-22 contract year. And then going forward into the plan year 2021-22, the current list of 17 was written into performance guarantee terms in the contract, and the measurements are based on the calendar year 2022 results, with the reporting due later this year. The summer timeframe is the expectation for that. The fees at risk apply starting with the 2021-22 post-COVID calendar year 2022 measurement year. And the carriers had asked for proposed changes to the clinical performance guarantee. Timeframe was October of last year. And now we are at the point of, we did review what was proposed from the carriers. We all chimed in, and I think what we are presenting today and reviewing is sort of the pluses and the minuses to define the final proposed set of metrics for the plan year 2023 to 24 / calendar year 2024. Okay. So this is the hierarchy of sort of the around performance metrics, but more broadly, I would say, just quality metrics and how we align our thinking around that. So with the starting from the bottom, so the base of the pyramid, we're looking at clinical performance guarantees coming out of the basis for it is the Health Plan Quality Metrics Committee, and it gets reviewed and prioritized. We recognize that performance guarantees should be aligned to sort of the things that matter for our members and OAB, but they are subject to reevaluation for a couple of reasons. One, are they measuring what matters to us? And from the metrics sort of world, what are new ones that are becoming relevant that needs to be further considered, either added or substituted for something that's in place? So this should be somewhat dynamic, with a caveat that obviously for anything that we are measuring, especially over time, some degree of consistency of the important measures so that we can track over time to make judgment about improvement, stability, or degradation of either process or outcome measures. So we want to definitely also be able to benchmark and get a sense of how well we are doing, not just in terms of trending improvement, but against sort of the best in class. And then lastly, recognizing that measures take work. They don't just naturally happen. So it's the alignment and the collaboration with our carrier partners. We look to HEDIS as sort of that starting base, and that have well-stated measurement criteria in terms of the codes and the logic necessary to measure that. So that gives us that consistency to allow us to compare, trend, and benchmark. So those are the framework for how these performance metrics, but more broadly, quality metrics are in place. Any questions or thoughts on that? Okay, let's go ahead and go through the list of the proposed changes. So these are color coded. So what the pink color is the ones that through the metric review meeting we had, they were proposed to be removed, and we'll explain sort of some of the rationale behind it. And then there were ones that were tabled by one or both of the carriers for consideration for removal, but we considered it was still important to keep them. And then others were added, and they're reflected in the green. So there's a cluster of 3 that were, upon discussion, were agreed to be removed. And they're really around sort of a really high-level generic sort of a activity-based measure that didn't give us insight in terms of any clinical granularity as to what was done. So it was basically, we would end up with a measurement that was inconsistently inconsistent what we were measuring. And they were basically, did you do a weight assessment? Was counseling for physical activity done? Very sort of too broad, too generic. Further down, the diabetic eye exam, as we were talking about the comorbidities and complications of diabetes, this was one that was deemed to be worth to keep in. And I think the carriers had suggested or tabled for us to consider removing that, but I think that is worth, the decision by the group was it was worth keeping. Next slide. 2 other ones that were tabled for consideration for removal, but we, after discussion, we kept, was around the statin. Next slide. So the statins are the medications to treat lipid disorder, cholesterol, and they are such a significant comorbidity and influence to cardiovascular disease that it was still worthwhile to keep that in place at a couple levels for receiving when clinically indicated, but also for staying on it as prescribed. The only other 3 additions left were also around the down below, the important preventative care and chronic condition management. So one is around the wild child visit for their first 30 months after birth. Very important for sort of for many reasons. So I think that makes logical sense. And we know that there's disparity in terms of early infant care that can be a risk. So that's something worth tracking. Cervical cancer screening is still important. And then the third one was high blood pressure control. Again, one of the comorbidities with cardiometabolic disorder. Let me pause there. Any questions? Anything further to add?
Just curious, what's the difference between CQ15 and the one on the previous slide?
Kristen, do you know? That one didn't have a number.
Oh.
CQ.
Bill, it looks like it was just a typo.
Yeah, it's the same thing. Good
Okay.
pickup, Bill.
Okay. Now, the other dimension that is important with these measures, like any measure, it gets all rolled into one value. But we realize for some of those process of care and outcomes, it's important also to understand any disparity or differences in terms of access, in terms of compliance by any of the potential disparity categories. So there was discussed around, how do we ensure that we are mindful and tracking around health equity. So the recommendation was to report on racial ethnic disparity around some of these measures, such as blood pressure control, breast cancer screening, colorectal screening, early infant preventative care, and diabetes control. I think these will be insightful to measure and understand, and if necessary, potentially, open the dialogue for what may be contributed to that, whether it's an access issue or an intrinsic treatment bias of providers or whatnot. But none of these would be sort of targets for a performance guarantee, at least for the 2024. But it would be informative and mindful of a potential area of risk.
And there was, during the conversations for the work group, there was unanimous agreement with what's being proposed here.
Okay. The next section.
Actually, I'm sorry, Dr. Chuang, I'm going to stop for just a minute. Is there any question from SEOW members and PEB members about these measures and the recommendation? This is a chance to say, I don't like this one. Why didn't you think of that one? Because this is one of kind of our SEOW's checklist of things that we need to do in terms of making recommendations to the board. No concerns heard. I'm going to assume that everyone is in favor of these measures. Okay, on to the methodology.
Okay. This is the current scoring methodology. Kristen, do you want to weigh in on some of these? I don't believe any of these were in place, right? There's no major changes to any of these formulas.
Yeah, this is the current scoring methodology, and the recommendation at that time is to continue with the current scoring methodology, potentially revisit it in future years, but this latest round of metrics and methodology is pretty recent.
There was one of our medical carriers had recommended a change to have more points divided over a larger range. In our conversations, we thought that this was a good one for us to continue working with. So again, the work group that talked through this, we were all in agreement to continue the current scoring methodology. Any questions from or concerns from the SEOW or PEB members? Okay, I'm going to assume again that there's agreement. Onward.
Okay, the other proposed change, next slide, is around the per Kaiser versus Moda. These were the summarization, and the recommendation was to keep the scoring methodology as well. So these are just how things are currently.
Yeah, this slide just illustrates what Tom went through.
Okay. And then the last just kind of summarizes the pluses and the minus, with the goal of keeping the metrics at a stable quantity and aligned to where we thought the biggest bang value of impact. Okay. So that was it for the medical performance guarantees. Back to you, Kristen.
Great. On the dental measures, we currently have 2 report-only measures with no targets or fees at risk. That's preventive service utilization for adults and preventive service utilization for children. And really the underlying reason for this is that there is no comparable benchmark to anchor to the way that we have for the medical clinical metrics. But it was the consensus of the work group that got together to talk about this, that, there is so much expertise on the carrier side that surely we can all put our heads together and agree on something. And so the recommendation would be to get a work group together to develop a target and potential fees at risk. And in year 1, it could be a report only, again, based on the metrics, but we would phase in fees at risk over time. And then the other recommendation to discuss would be adding oral evaluation for adults with diabetes measure as report only for the initial year.
And the thing that was particularly attractive about the last one, the oral evaluation of adults with diabetes, was that it would work to look at collaboration and coordination between the dental plans and the medical plans. We thought that that was this idea of dental medical integration where appropriate. This would be a good one for us to test out. This has been on my agenda for about the last 3 to 4 years. I've been a broken record and have not been able to move this not just over the goal line, but beyond about my 20-yard line. So I'm hoping that we'll be able to address this number, the first sentence there, request the carriers to come up with it. The problem has been there's been measures that have included sealants that have been approved by the Health Plan Quality Metrics Committee. The problem with it is the metric is around 1 year, and there's some people there's overlap. And again, we got prevention services took a huge hit during the COVID years. So hopefully we'll be able to nail this one down. But as you're seeing here, the recommendation for 23-24 plan year is that there'd be no fees at risk. Any questions or comments from members?
I was just thinking out loud, what are the knobs for the provider on these two metrics? Just advertising? I mean, how do you, are you going to go to people's homes and bring them to the dentist? What does the dentist do to change these values?
Yeah, the dentist does outreach. The dental office does outreach. The health plan, the dental plan does both outreach and education. Entities do education about the importance of this. The medical plans learn about the importance of people with certain medical conditions, their need to have ongoing dental care. There are no recommendations currently under the Health Plan Quality Metrics Committee that have medical plans being responsible for their, select populations getting dental care. We probably will be released from that stricture of needing to have metrics approved. So we actually could come up with a metric where the health plans are responsible, the medical plans are responsible for their diabetics getting oral care. It's all encouragement. I mean, we live in a free society where you can choose not to get care if you so choose, but it's our job to educate and to encourage and promote. A great example of that, Bill, is what Willamette Dental Group did when they waived their the office copay for the first visit, for new members, getting them in. Does that address what your concern?
I can see the cost. I'm just thinking rural Oregon where it's 30, 40 miles to the dentist,
Sure.
and you're just not going to get there. Right.
Yeah.
Anyhow, enough said about that.
No, it's a critical issue, and as we had talked about back with the medical measures, asking our plans to report on the basis of race and ethnicity, a possible equally important issue is going to be geography. And so we will, what you just said, we will take that and have our dental carriers, as they look at targets and measurement, of whether or not we can do it with a geographic focus also.
Yep, I concur. It's just the utilization just can't be one value for everything. It's got to have some adjustments based on those kind of factors. Yeah,
I get it. Okay. Any other comments around the recommendations for the dental measurements? Okay. Onward.
This was just, we brought in a snapshot of last October's results, just in case there was a question about it, but we did not intend to walk through this again in detail because we just all We just all saw it, so it's more of an appendix item. So I think that's it for the PG deck on the Mercer end, Tom. Tom, you might be on mute if you're talking.
And I am on mute. Now I'm not. Okay, let's go down then to the we've been just talking about diabetes. Let's go to the diabetes measure. So it'd be the next slide. Let's see if that's it. One up, yeah. So it's number it's PM 11. It says comprehensive diabetes care, hemoglobin A1C, poor control. And I believe that's ideal. The goal for diabetics, at least that has been, to be at 7% or less. Poor control is if you are 9 or higher. And so what we're looking at here is the performance. This is the MODA numbers, and we'll look at the Kaiser Permanente numbers in a minute. But it shows the first 3 are 2019, 2020, 2021, and these are the people who are in their care management program. And you see it at 25%. Again, low is good, worsened significantly to 31%, improved to 27%. And if you look at that 27% and look at it from the now to the second to the right, 2021 PPO, 75th percentile, it's 30%. So for the people in the care, in their coordinated care model, they were better than the 75th percentile, slightly lower than the 90th percentile, and you saw that dip, and this is what we had talked about for the last 3 years. The dip related to what happens to people who, during the pandemic. The number and that's also between 2019 and 21, it's a changing population. So we don't know, when you look then at the PPO, I'm looking now, so it's 1, 2, 3, 4, 5. The sixth one, 2021 performance PPO for it, it's jumped up to 47%. That's a different population than was from the year before, because MODA changed their coordinated care model. That shows the complexity of looking at data over time. If we look at the PM number 12, it shows the percentage of diabetics who are receiving statin treatment: 61, 63, 65. Actually, during the pandemic, even with the pandemic, things got better for the coordinated care model. So they're basically at about 66%, and the 75th percentile is at the 68%. So let's now go to the Kaiser ones and to the similar. Okay, so this is, we're looking for comprehensive diabetes care A1C, 21.7, so 22% in 2019, and then you have the PEB number at 25%. You go to the fourth over, 2020 MY stands for measurement year OEB, 32%. So this is the dip that happened with control for diabetics. PEB went from 25 up to 36%, and then measurement year 21 for OEB dropped from the 33% down to 29%, and PEB had dropped to 30%. But you can see then for the HEDIS numbers, it says percentile CCO. I think that's HMO benchmark. and you can see that they were way off there. The bottom line is for statin use was at 68%, went up to 69%, went up to 70%. No, I'm sorry. Those are for OAB, it went from 68% to 67% to 68%. So pretty flat. And both of those are less than the 70th percentile. So it shows that, I mean, these are some of the things that we can track. These are the types of outcomes are specifically related to these two measures. These do have significant impact, and we will watch them over time. Again, the pandemic had a pretty huge hit, but when we work with as we look at talking to our health plan partners, as we get the obesity and diabetes long-term management issues and coverages, things worked out, that work group will be looking at these over time. Any questions? Okay, I don't think so. I'm not hearing any. So that is our recommendations are as outlined. We'll bring that to the board. This is a chance for anybody to give us any comment or discussion. Rose, do we have any public comment? Rose, are you there?
I guess we'll take it as a no.
Well, and Glenn, do you know of any public comment?
I haven't heard of any public comment.
Okay. All right. So with that, I'm just doing one last check. Okay. Rose, you're muted if you're... Okay. I'm going to assume we don't have any public comment. And with that, I will call the SEOW meeting for March complete. Thank you very much to the Mercer team. Very helpful presentations, very well organized, and lots of work to do. Bye-bye.
Thank you.
Bye, everyone.
Thank you.
Bye. Thank you.